I'm very excited for today's webinar. Today's topic is going to focus on the hands and scleroderma. We have two fantastic speakers today. We've got Amy Gietzen and Dr. Michael Macklin joining us today. But before we kind of get started with the webinar, I do have some opening comments. So just to make sure everyone's logged in correctly, you should see my face and the faces of our two speakers on your screen. You should also be able to hear audio. If you're having any audio or visual issues, please try logging out of your Zoom account and logging back in. If the issues persist, please message me directly in the chat feature and I can help assist you during the webinar. Today's webinar is also being recorded, so if you have to jump off earlier, if you want to rewatch the events, please check out our YouTube page. It's YouTube Scleroderma US. And you can check out all of our videos, including this one, and this video will be posted by Friday afternoon. I'd also like to let you know that the National Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it's strongly recommended that all drugs, treatments be discussed with your physicians for proper evaluation and treatment. This webinar is for educational purposes only. And then lastly, if you do have any questions during the webinar, please feel free to put those into the chat and the Q&A. And at the end of the presentation, I'll be going through those questions with our speakers during the Q&A portion. So with that said, I'd like to introduce our first speaker for today, Amy Gietzen. Amy Gietzen has been part of the National Scleroderma Foundation for over 12 years. She's been living with scleroderma for close to 25 years now. She's been a longtime advocate for scleroderma. She's gone to Capitol Hill. She's spoken at several conferences. She was the originator of the support group, the SYNC support group leader, which is Young Adults Seeking Connection. She's a member of our Tri-State chapter and a member of the board for the Tri-State chapter. Thank you for joining us today, Amy.
Thank you, Angel. I appreciate it for having me. So I'll just dive right in, I guess. Most of you probably know a little bit about my background, but I was diagnosed with systemic scleroderma in 2001 at the age of 19. And really some of the first symptoms I had to do with my hands. I had a lot of like wrist and elbow issues. I couldn't really bend my fingers. They were turning purple all the time. And that kind of led me to go and seek medical attention. And ultimately I found out that I had scleroderma. In the beginning, it was pretty rough in terms of dealing with a lot of the symptoms. My hands were really bad in the beginning. I had a lot of ulcerated sores that had developed because I had really bad Raynaud's in the beginning. And, you know, some of my fingertips turned black or purple, and you could see like I've lost, you know, some of the digits on the top here from natural amputation from having those sores. So it took me kind of a while to figure out like what's happening to me, what's happening to my body, how am I going to figure out, you know, what to do. And locally here, there wasn't a lot of options in terms of treatment in 2001. So I had to kind of do my own advocating and research and things of that nature. So all the kind of things I'm going to lay out for you are things that I did and have worked for me, but I would absolutely recommend that you go and talk to your doctor about any of the treatments. Don't go out and buy stuff just because, you know, I've done some of that and had really awful, unsuccessful things. So my first kind of issue, what like I said, was with ulcers. So I really had to try to figure out how to stop getting these wounds because some of it had exposed bone, you know, and it's really hard to kind of use your hands when every time you move them and just a light breeze really hurts. So my first kind of big thing was pain control. I went to my rheumatologist and kind of went through a plethora of like creams and things to try to alleviate some of the pain. I would absolutely recommend that you get a wound care specialist when you're dealing with these types of wounds. A lot of times, like rheumatologist or your general practitioner, they know a lot about scleroderma and about how to deal with this, but you really need like a specialist, especially if they get infected, or you have to go on antibiotics, or you have to have debridement of wounds. So that would be a number one big tip, would be have a wound care specialist. I would also recommend having a hand surgeon in your back pocket if you could. Pretty early on in my disease, I had to have a couple surgeries. I had sympathectomies on both hands, which is where they kind of cut into and rearrange some of the veins in the wrist to help promote circulation to the tips, to the digits, and help kind of heal some of those sores and help with, vasculitis and things of that nature. So having a great surgeon that knows about scleroderma, I would say, is a must. When I'm dealing with my hands today in this day and age, I try to keep them as dry as possible. It works for me. It might not work for everybody. When I shower, I use special gloves. They're like mitts, plastic mitts, and I kind of like medically tape the wrist so you don't end up with like a big ball of wet water inside like a balloon, but it helps to keep them dry as can be, because I find that when my hands are really moist, that breeds for like cuts and sores for me. I also like to keep my hands as warm as possible. Everyone knows if you live in the East Coast that you want to have mittens, hand warmers, keep those hands and your core as warm as possible. For me, I didn't just get sores in my hands, I got them, inside of my nose, inside of my mouth, on my elbows, on my toes. So you want to try to keep your body as warm as possible. Um, Anytime I have kind of like a pressure point where like you're doing a lot of writing with your pen, or I did a lot of painting and you're pushing on like maybe this bone here or here, it kind of leads to you getting like a pressure ulcer. So I always like to kind of take breaks, rest your hands. Um, and I would say PT and OT saved my life with hand therapy. I really had great exercises that they gave me to stretch my fingers, stretch my hands. My therapist was great. She said, if you don't use it, you will lose it. And it really helped me to keep my range of motion somewhat intact when I was dealing with like contractures or, stiffness with the skin and the joints. Um, I use Manuka honey a lot for sores that are not infected. You can buy special Band-Aids that are sterile with Manuka honey, and you kind of just put it over the wound and it stays. You can take a shower sometimes with it on and it'll stay on. Otherwise, I put it on for the whole day and then take it off at night. Or they have actual cream, but that can get sticky because it's honey. So you don't want to wake up like with your bed sheets all covered in honey. That wouldn't be a great idea. So that you can buy over the counter. I really got into a lot of splints when I worked with my OT therapist, because my hands were kind of curling in. So what they did was create splints, and I would wear them to sleep, and they would kind of keep the joint, the spaces in between my fingers open. That helped a lot. I also had a surgery where they went in and they took, as you can see, like on my pinky, how it's curved like this. They went in and they actually, they kind of broke the knuckle and straightened the digit out. Now, you wouldn't be able to bend them all the way, like these three fingers are done. So I can't really bend them all the way, but I didn't really bend them to begin with. And it helps to hold like a cup or a doorknob so that your hands are not like this. So I had surgery on both hands to do that. That's why I say having a hand surgeon in your back pocket is a lifesaver. I've done a lot of treatments. I've done hyperbaric for wound care, which is where you go in like oxygen, they kind of bump up the oxygen and you kind of lay there. It's like a tanning bed. Um, that's a long arduous process. I had to do like 40 weeks of it. Um, but it did help. I had some exposed bone and it really kind of helped to regenerate some of the skin. I think that's kind of really it. I would just say you do the things that work best for you. For my 25 years of living with this, I've had a lot of lived experiences, but you know kind of your body and you know what works well for you. Um, and anytime you hear a tip or a trick from anybody else, just take things with a grain of salt. We all know that scleroderma is a disease that affects everybody very differently. So I think um, you have to kind of take into consideration that some things may not work for you and don't get upset. There's a lot of different ways to treat um, scleroderma nowadays than there was over 2 decades ago, and I think we're on a good path. So, and with that, I'll hit it back to you, Angel.
Awesome. Thank you so much, Amy. That was very informative, and I really appreciate you sharing your story with us. I'd like to introduce our next speaker, Dr. Michael Macklin. Dr. Macklin is a clinical rheumatologist with a special interest in systemic sclerosis, autoimmune lung diseases, and vasculitis. He's part of a multidisciplinary interstitial lung disease team as well, which also includes pulmonologists, radiologists, lung pathology experts in the field of interstitial lung disease. Dr. Macklin is also leading a multidisciplinary care team for systemic sclerosis at the University of Chicago, with an interest in clinical trials and clinical research to advance treatment options for this challenging disease. Thank you for joining us today, Dr. Macklin. The floor is yours.
Well, thank you so much for that lovely introduction, Angel. Let me just figure out how to share my screen. Is everyone, are you seeing the presenter view?
Perfect. Now it's in presenter view. Yep.
Okay, wonderful. All right, but yeah, again, thank you so much, Angel, and thank you so much, Amy, for sharing all of those helpful tips. And so again, I really appreciate being invited to talk with everyone today. My name is Michael Macklin, and I'm over in Chicago, University of Chicago, and really have a big interest in hopefully being able to move forward treatment options for systemic sclerosis. And so today we're going to kind of do an overview of the hand and scleroderma. It's not meant to be, a very detailed presentation for every single possible issue with the hand and scleroderma, just more so a general overview. So there may be some other really, really good ideas, like for example, like Amy mentioned about potentially using MetaHoney on wounds. I didn't happen to talk about that, but so it's not, there may be some other things that are helpful that aren't in the presentation. So I just have one quick disclosure. It's not really relevant to this talk. I happen to work with Amgen on a couple of things, but neither of these two medications are even used in scleroderma. So, but there's a FYI, that's my disclosure. And so our outline today, we're going to go over kind of general hand care, Raynaud's. We're going to talk about this funny sounding word, pterygium inversum unguis, which we'll get to in detail to some degree, but is really kind of having these fused nails to the nail bed. Calcinosis, contractures, acrosteolysis, and inflammatory arthritis. And so one of the big features for systemic sclerosis is Raynaud. So by definition, almost every single patient with scleroderma or systemic sclerosis, which I'll kind of use interchangeably throughout the rest of the presentation, pretty much you have to have Raynaud's. But the degree of Raynaud's is incredibly variable. It really depends on the type of disease, a type of subtype of scleroderma that you have. Some it's very mild and very manageable. Other people, unfortunately, do lose either parts of digits or full digits with severe ulcers that get infected or low blood flow states to the digit. So it's very, very variable. Not everyone's going to have all these issues, of course. But it's very common on the upper left for people to develop these kind of pitting scars where there may have been an opened up scar or opened up wound from the Raynaud's causing kind of low blood flow. So then the tissue gets damaged and opens up. and then it kind of scars over time. So people will have these pitting scars. And over here is on where there's a red arrow, you can kind of see that this person unfortunately has that part of the digit missing. And so people can develop kind of missing parts of their digits, either due to the Raynaud's itself causing, infections, and then unfortunately that has to be amputated if it can't heal. Or there's another process we'll talk about later, which we don't fully understand, where the bone itself kind of gets resorbed over time. So that's what's going on in this person. And we can kind of see more example here. These are kind of more actively open on this patient, the ulcers. So this is from Raynaud's. And again, not everyone will develop this to this degree. The other issue with ulcers that develops as well, so these ischemic or like low blood flow areas are from Raynaud's, but people also get these traumatic ulcers that are kind of further up on the fingers. So we can see here in the bottom that these are not the tips. The tips are usually from Raynaud's, but over here, a lot of people develop contractures, so the hands kind of held in an unnatural way, and you really can't protect it like you normally would. So people will kind of bump their knuckles up against things, and over months to years of doing this, you can actually cause these ulcers. So these are more so traumatic. These are treated a little bit differently than trying to have medications, improve Raynaud's. And so there's some general hand care suggestions. While water can definitely, like sitting water in hands, can kind of break down skin. In general, like a lot of people can get into issues, especially in colder climates in the winter, where the dryness causes a lot of cracking, and then that cracking causes the skin to open up and they can get infected. And so it's especially in colder climates a good idea to keep the hands not moist with water, but moist with kind of creams, ointments, etc. And so there's kind of a order of lotion, cream, ointment. So lotion's kind of the most pleasant to use, but less moisturizing, while ointments are the most moisturizing, but they tend to be a little bit on the greasier side, and creams are somewhere in between. There's several different options. I kind of put some down myself. Like Eucerin's pretty good, Aquaphor's pretty good. I actually am a fan of this O'Keeffe's Working Hands. I use it myself. I get cracked hands, and it leaves kind of a film that helps really, help those areas that are cracking. And then I'm in Chicago, so it gets cold here. This is probably less of an issue in warmer climates, but again, in the winter, it can get really, really crack prone on fingers and hands. So I have a lot of my patients use some sort of humidifier in the winter to kind of keep the air moist. Even just while wearing gloves can be really helpful. These are kind of like a soft glove, but for people with really dry hands, which can definitely happen, you kind of will apply one of these products first, like right before bedtime, kind of saturate it, and then you kind of leave the gloves on after that before you go to sleep. And that really kind of helps lock in the product and really helps really aggressively dry skin. But of course, this is different from person to person, and also different from climate to climate. Some of the the lotions again are more comfortable to use, but they don't do as good of a job as the creams and ointments in actually moisturizing. For like very significant fissures or cracks in the skin, because you really want to protect it and help it not get worse, and hopefully have it heal up. You can just cover it with a physical barrier, so Band-Aids are fine. Vaseline is kind of the most moisturizing thing out there. It's just very unpleasant to use. It's very, very greasy. But this is an option for very, very, very dry skin. And then they have these liquid bandages, which do a really good job of kind of protecting anything that's open. I would just caution people, if you think an area is infected, you don't want to use this, because if something's infected, it needs to drain a little bit, and this kind of stops that process. So you wouldn't want to use this like liquid bandages on any sort of open wound that looks like it's getting infected. But outside of that, this is another good idea as well, and it really helps keep those open areas covered. As far as things to avoid that can really irritate, open wounds or very delicate skin. So when I say avoid Tide, you can still use Tide and stuff, or like aggressive detergents for your wash, but you probably want to put on gloves, because if you get a pretty decent dish detergent or a laundry detergent on your direct skin, that's really irritating. That peels away all the moisture on the skin. That can even either irritate or worsen some ulcers that you have, or maybe even make your skin more prone to cracking open. So if you're handling some sort of aggressive detergent, you really want to make sure you're using some sort of protection. So you can just make sure you're using gloves if you're using one of these kind of products. And then Purell's all over the place, especially after the pandemic. But the alcohol in this is very, very drying. It's very, very irritating. It's going to sting terribly in any sort of open wound that you do have. Hand washing is almost always a little bit more tolerable and better for the skin. So I would limit Purell use in most people, if possible. And then, kind of in the same vein of having products that are, easy for the skin to handle. A lot of, commercial soaps have a lot of fragrance in them, or other kind of aggressive cleaners that, again, may not be as tolerable if you already have kind of fragile skin to begin with. So there's a couple of products that are, very gentle, and they're good for people with, systemic sclerosis, with eczema, etc. Like really where the skin barrier is kind of, impaired. So something like a Dove beauty bar. It's fragrance free. It's moisturizing. It's not irritating. Cetaphil also makes a product. There's a couple other ones, but some sort of soap that would be advertised for sensitive skin, and staying away from heavily fragranced bath products is also a good idea. And it's really important when a ulcer is looking infected. You definitely want to let your rheumatologist or other doctor know, because they can be really, really troublesome. Of course, infected anything is always, in any patient or any person, is not a good thing. But people with systemic sclerosis have a lot of trouble clearing infections because the skin barrier is so compromised, and the skin is just open. So we tend to be more aggressive in people with systemic sclerosis. It's really early use of antibiotic creams, and then even sometimes pretty early use of oral antibiotics, because we really don't want to have a deep-seated infection that can really have a poor outcome if that happens. So I personally, so this is prescription only. I prescribe mupirocin to almost all of my patients with Raynaud's, and I instruct them, if the wound's been open for a bit, or is having some discharge, to start this for a couple of days. The general antibiotic that helps us hopefully avoid any more deep-seated infection. The main over-the-counter antibiotic cream, it goes by a couple of names. This is like the generic, but triple antibiotic ointment will be what it's called generically, or this is Neosporin by brand. It works fine. The issue, which we'll have a picture on next slide, it can actually irritate the skin. So the bacitracin in it and the neomycin are two of the most common drug-induced causes of contact dermatitis, which is a like allergic reaction, and that also opens up the skin as well. So it's usually fine for short-term use, but the reality is people with systemic sclerosis are going to be probably using something like this pretty often, so it could become a problem over time. So I prefer the prescription options. This is not in a systemic sclerosis patient, but this is just an example of what contact dermatitis is. So this is a picture of someone who got contact dermatitis from prolonged use of Neosporin, essentially. And again, bacitracin and neomycin, those are two of the three antibiotics. They just happen to be a pretty common cause. This can still happen very rarely with prescription options, but it's much more common with the over-the-counter one. So it's just something to be on the lookout for. And then just even general hand protection. So this is most helpful for those kind of traumatic ulcers that are further up on the fingers. So these are your PIPs or even the MCPs, so like the knuckles, and then over here. So, those are kind of more chronic, and as we'll get to later, those don't respond to Raynaud's management because they're from a different mechanism. They're from just the hand. Usually patients have some sort of contracture and it's just banging against things, not even intentionally, we notice necessarily. So it's just that kind of chronic trauma over time damages the skin. Something that could be helpful is just kind of giving some cushion between the skin and the outside environment. That can be accomplished with with a glove. These are like biking gloves. So they just will kind of cover areas. So if you have open areas that are small, this will hopefully help prevent them from getting bigger because you're going to help protect that underlying skin. Or they have these little silicone finger sleeves that you can kind of cut to desired length and just kind of protect any sort of delicate area. Now, this won't help with Raynaud's ulcers because, again, that's different, but this really helps protect some underlying skin from some of these more traumatic ulcers and can be something that people find helpful. Of course, in the winter, you had like a full set of gloves that will help, with Raynaud's, and that because that helps all this help, with temperature regulation. But that would be kind of a longer, more normal glove length. And then getting to Raynaud. So again, pretty much everyone with systemic sclerosis has this, though it's very, very, very wide in how severe it is. This is, a picture of very typical Raynaud's. It's the color change, it's the tingles. It can be very debilitating, especially if you live in a cold climate. People can't go outside as much. It can be interfere with work. A lot of workplaces blast AC, and I've had to write notes for people to move their seat away from the vents and everything. But this is kind of the stereotypical Raynaud. You have this color change. You can get tingles, and this is kind of how it looks like. And then in severe cases, like we already showed, you can get ulcerations. And Raynaud's itself is very, very common. That's known as primary Raynaud's, though, where it's happening without any rheumatic condition. Secondary Raynaud's, where it's from something. So systemic sclerosis is the most stereotypical one in rheumatology. There's a couple other autoimmune diseases that also often will have secondary Raynaud's as well, but it tends to be more severe, and you tend to see changes to the nail filled capillary, to these little tiny blood vessels that you don't see in primary Raynaud's. So you can see here, you have these little areas of telangiectasias, which are dilated blood vessels that you can actually see with your eyes. So it's kind of scattered along this person's hand. And then it's a little blurry, but this person also has a little bit of ulceration as well. And not all rheumatologists will do this, but some do, including myself, where we take a look at your nails, sometimes with a microscope, sometimes with an ophthalmoscope, but you can kind of see these dilations. So normal blood vessels are kind of thin and regularly spaced out. These are pretty big, and this is usually a sign that there may be like a secondary Raynaud's going on. This could be helpful for diagnosing scleroderma as well. And this is just another picture of what I'm talking about with these nail-filled capillary changes. So the top left is normal. You have these little nice loops. They're thin. They're evenly spaced out. And you can have, so this brown business is actually blood. These are areas of hemorrhage. You have these unusual shapes. They're very large. They're not evenly spaced. You can have dropout, where there's this little area in the top right where there's no capillaries. So you see this combination of abnormalities, and that can sometimes point for like very early systemic sclerosis that something is going on. And there's some general, non-pharmacological measures for Raynaud's. Some of these are easier said than done. But again, in colder climates, having some sort of hand warmer can be really helpful. They sell little chemical warmers that you kind of hold in your hands. You pop them, and then they make heat for a couple minutes. Or you can also have electric ones. I have had some patients get battery-powered gloves. You also can have more of, like, they use it like in the NFL, this kind of it's like a little tube that rests near your stomach, and you kind of put your hands in it, and it's electrically heated as well. Having a heater, space heater when available, layering, cold avoidance, which again, easier said than done. Unfortunately, a lot of new cars, they lock the heated steering wheel at the top of the line option, but that could be really helpful as well for people. a really important factor is if someone is smoking, just to stop. That's, good for your health for a variety of reasons, but smoking definitely makes Raynaud's a lot worse. So that's something where someone is smoking, we really try to do what we can to help. And this probably also extends not just to tobacco smoke, but really any sort of smoke, whether that be marijuana or anything else. Marijuana itself is probably fine in most cases, but smoking it, like the inhalation route is not good. There's often a lot of drugs that can also often trigger or worsen Raynaud's, and some of these people are on for other reasons, but these could be things like migraine medications, high caffeine intake, clonidine, which is a blood pressure medication, people on stimulants for ADHD, and beta blockers, which is another kind of blood pressure medication. But those can worsen Raynaud's as well. So we do what we can to either limit those if someone's on them or find alternatives when possible. And like I alluded to, most rheumatologists are really going to want to hear from you if you have open ulcers, because we really want to do everything we can to not have them get infected and then not have a deep-seated infection. But that's really, really hard to get rid of. So we definitely want to hear from you in most cases. And my own practice, I am pretty aggressive with antibiotics if they are starting to have this discharge, and especially a white discharge that tends to be consistent with pus and means we definitely have to do something. And like Amy mentioned as well, I will often refer to hand surgery in some of these cases as well. Sometimes people need some debridement to take off some affected tissue if it's very, very bad, but definitely it's important to keep your doctor in the loop. As far as drug therapy is concerned for Raynaud's, there are several options. The reality is the two that are bolded are the most evidence-based, and everything else has some data, but is less preferred because it's not as much information that they work. But calcium channel blockers, amlodipine, and nifedipine are kind of the first line therapy most people use. And then usually if that fails, we're doing something like sildenafil tadalafil, which is a phosphodiesterase 5 inhibitor. That's real. Those two drugs really are a standard of care therapy, and they can be used in combination. One of the more common problems that can develop is a lot of patients with scleroderma have very low blood pressure at the get-go, like they just naturally are on the lower side. And calcium channel blockers lower blood pressure. Sildenafil tadalafil can as well, but less so. But it becomes an issue because really one of our most effective therapies is this drug class, but then they're not safe to use if you have very low blood pressure. So that can become an issue, though you can get nifedipine compounded. So as a pharmacy not all pharmacies do this, but there are compounding pharmacies who will custom make a cream of nifedipine. And the idea is hopefully the nifedipine in a cream will work just as well as the oral, but not be as absorbed, so have less of an effect on blood pressure. And like I mentioned, everything else after this is less evidence. As an FYI, so something I come into regularly, insurance gives a lot of trouble about sildenafil tadalafil sometimes. Not always. It depends on the exact plan someone has, but it's not rare where there's some pushback. And so in those instances, I've often just done this. It's owned by Mark Cuban. He has his online pharmacy called Cost Plus Drugs, and this one basically they don't use any sort of insurance. It's just basically direct pay. But it's fairly affordable. Obviously, all of these out-of-pocket costs add up, but it's in this ballpark, under $10 a month, essentially, for 30 days worth of one of these drugs. So I've often just switched to this, and I think it's just worth knowing about because it's substantially cheaper than the out-of-pocket costs without insurance at CVS, Walgreens, etc. So it's just something to be aware of. Not all doctors are aware about this. As far as other options for Raynaud's, there are several, but again, they're kind of less evidence-based. I do use fluoxetine losartan. Fluoxetine is a antidepressant medication, but there's some evidence that this may help with Raynaud's. Losartan is another blood pressure medication. Again, kind of the same issues with low blood pressure, but it's an option if someone has pretty robust blood pressure left. There's very poor quality evidence for aspirin. I don't personally use it, but there are some people that do. There's also very poor quality evidence for this medication called fentoxifylline. It's a 3 times a day pill. I don't personally use this very much, but it's another option. There's actually a little evidence for atorvastatin, which is a cholesterol medication. This one I do use. There's a little bit of there's pretty good data that people with systemic sclerosis probably have more heart disease, and so there's often another reason to be on it anyway, as that's pretty well tolerated. And then there's this medication called bosentan. It's used for pulmonary hypertension or high blood pressure in the pulmonary vessels, which is another thing that happens in systemic sclerosis. But this is in regards to Raynaud's. There is a trial that showed benefit, but it really only showed benefit in ulcers, but only in people with tons of them. There wasn't really any difference at the low end. It only really showed a benefit in people with like 4 or 5, or like I think it was over 4. Plus, there's some other issues with it. It's very expensive. There's a risk of liver injury, so it's kind of a niche medication. Other options, some of which are a lot more invasive. There's this drug class called prostacyclin analogs. Epoprostenol is pretty typical. There's a couple other options as well, though. A lot of different hospitals have their own kind of protocol, but this is usually in emergent cases. This would be a time, like I mentioned, where we really want to know if things are not going well. But people have kind of either an ulcer that's just not healing no matter what we do, or kind of has a digit threatened area. This is an option kind of to try to bring back blood flow to that part of the hand rapidly. There's some controversy about botulism toxins. It's unclear if they help. I definitely met patients where they have, but the actual literature actually even suggests harm in some people. So it's not clear if these work. The idea is basically the botulism toxin stops any sort of blood vessel spasm, but it also stops blood vessel dilation, which is desirable. And they're of course painful. It's an injection. There's fat grafting, so people have a lot of fat wasting in the hands, and that may worsen Raynaud's, not just because of like the insulation from the fat, but fat's actually very metabolically active. So some of the signals from fat may actually help Raynaud's. So people can kind of have fat from other parts of their body kind of transferred to the fingers. So there's a little bit of data for that. This picture is showing fat grafting. There is digital sympathectomy. This is pretty invasive. This is a big surgery with a hand surgeon where they kind of peel off some of the nervous system that is controlling some of the blood vessels to help stop them from having so much vasospasm. But this, there's mixed data, but it's very invasive. We try not to do this when possible, though it is an option. And there's a couple of case reports of spinal stimulators as well. So these are mainly used for chronic back pain, but there's a little bit of evidence this might help with Raynaud's as well. But a lot of these options again are much more invasive. Calcinosis definitely affects a subset of systemic sclerosis patients. It's most typical in people with a PM-SCL antibody. This is a myositis overlap syndrome typically, though it can happen elsewhere. There's unfortunately limited treatment options. There's a little bit of data for minocycline. This is an antibiotic and also used for acne. There's a little bit of evidence it might help for calcinosis, though. I do use it, but it clearly doesn't do the best job. There's also a medication called sodium thiosulfate. It can be injected into the actual area. It can be applied as a cream, and it can be infused. I think the issue is very painful to inject into the area of calcium, which we'll kind of see in the next slide why that would be very painful. I don't personally do that. I don't think the creams work. Infusions we've done a couple of times but the issue is you have to get this 3 times a week, so it's a big commitment. Mixed evidence there. So infusions are just when you have an IV treatment, and so it's infused into your vein, but it's a big time commitment, and it's very often, so it's not an ideal therapy. I have referred people to surgery in cases, usually where it's a very large area of calcinosis, to try to debulk some of it. The issue with surgery is it comes back. So surgery itself can stimulate calcinosis from the wound healing effect and the local inflammation of the surgery itself, but we still sometimes try it as a very large area. Just so we hope that the end result is still a benefit. But for like a small area, it can often come back because the surgery itself stimulates calcinosis. And then in myositis, which there's a subset of patients that have that as well with scleroderma, and that's just muscle inflammation. Calcinosis also happens in that disease. There's a little bit of data for JAK inhibitors, which is another kind of immunosuppressant. There's tofacitinib, upadacitinib. There's not really any data of this, though, in systemic sclerosis calcinosis, but that's a potential other option. And this is an example of calcinosis. So people will kind of have this like kind of chalky substance that can come out. And it's, with outside this chalky substance, you'll have these little nodules that are very hard. Now, in some people, it's just cosmetic. Some people, they just have a little bump there, and it's just there. While in other people, it's unfortunately very uncomfortable. It can be very painful. And people can have very, very extensive calcinosis in different parts of their body where it can really interfere with function of that limb. This is an X-ray. And again, this is on the more extreme side. It is much more typical of people to have little areas like this, not to have something on the left. But this is an example of someone with very extensive calcinosis. So the calcium deposits will come up in X-ray, so you can kind of see this person has very extensive calcinosis. So so like everything else with scleroderma, there is a very wide spectrum of severity here, even when we're talking about the same complication. So then this funny word, pterygium inversum ungus. This I've seen in many of my patients. So basically, it's referring to when we can see in this picture, the nail kind of gets fused and stuck to the underlying nail bed. And again, in some people, it's more of just a cosmetic issue, but there's definitely people that have very significant discomfort. So it can be very painful. And it's not fully understood why this happens. It's not that well researched, unfortunately, and it's kind of a forgotten complication of scleroderma. But the theory currently is that it's probably from the Raynaud. It's probably that the nail and the nail bed are being damaged by the low blood flow states and with Raynaud's, and over time that causes this abnormal kind of nail growth that can happen. And it's not really well known at this time how to actually intervene. There's a couple of case reports of people using electrodissection, which is a pretty, again, an invasive approach. And then there's a single case report that I could find of botulism toxin injections helping. But as we kind of alluded to, that's kind of becoming more controversial whether this is actually a good thing to do or not over time. There's also one case report of this. It's kind of an over-the-counter herbal product we'll talk more about, called hydroxypropyl catechin, which would not be invasive and may worth a try for some patients, though I get the evidence is not really there, which we'll talk a little bit more. But these two pictures are from that one case report of that herbal product. So I will say the pictures here are clearly under different lighting. So it's not the best before and after here. But you can kind of see how severely this was kind of fused, and you can kind of see the pterygium inversum unguis pretty well here, and basically it looks a lot less severe after 4 months. And the patient basically thought there was less discomfort and everything as well. And so there's little other data for this product outside of this exact indication. So what is hydroxypropylchitosan? It's a modified crustacean shells. So they modify them, and that's basically what it is. And they make it in a nail lacquer. There's a little bit of data that may help in general with brittle nails, outside of systemic sclerosis. There's this animal model about it strengthening nails from fungal infection. And I will note though that the tested product in that one case report, it's this combination of the hydroxypropylchitosan. This is just a plant derivative that's like high in phosphate, which is needed for nail growth, and methyl sulfonylmethanes is kind of a general, almost like a solvent. But this kind of combination of products, I looked extensively, is not available in the United States. But this is exactly what they tested. It's actually a German product. I looked into it a little bit more. The actual product itself is about $20, but it's again not available in the US. I couldn't find something that's identical. So it's probably about $60 internationally. I just had someone try this. I haven't seen them again yet. But it may be something worth discussing with your rheumatologist, whether it's worth trying. At the very least, it's not invasive. It should have pretty minimal risk. Again, the efficacy data I wouldn't say is there per se, but it may be something to try. Contractures are unfortunately very common in the hands. So this is a lot of patients with systemic sclerosis end up getting contractures at the PIPs, that's these joints over here. So they're kind of held in flexion, and because of the skin thickening and the tendon thickening, you can't fully extend them. So this can be very debilitating. The hands are, of course, really the most, I mean, I think it's fair to say that the most important parts of the limbs. We use them to interact, we use them to eat, we use them for everything. And you could imagine, even if you hopefully don't have contractures like this can be very debilitating. And a lot of patients do have some degree of permanent contracture, but the goal is to lessen it as much as possible and to improve function as much as possible. So most patients with systemic sclerosis, the skin does soften over time. It doesn't usually normalize, of course, but it does tend to soften over time. So with time, these may get a little bit less severe. But it's really, I think, important to see OT or PT very early on. So basically, by doing exercises, either with putties and other interventions, and stretching, even if the skin is very thickened, that can help increase the elasticity a little bit and help minimize. Again, the realistic goal is not to get rid of them completely generally, but at least improve. And even with people who have, unfortunately, some permanent disability, there's often some assistive devices that could be helpful and help people have a better quality of life and be able to maneuver around our world better. And so these are just some examples of assistive devices that could be helpful for people with pretty extensive contractures. Because again, the issue is you have a lot of trouble using the hand. So OT is a really great area where they can help troubleshoot, and there's lots of different grip options and everything. But this is like a toothbrush, for example, that has a very large grip, so someone really can't control the hand that well because of the contractures. It's maybe easier to get their hand around something big like that than like a little tiny toothbrush. And this would be like there's different instruments like for like utensils, so spoons, knives, etc., that kind of attach lower down on the hand and help make it easier to eat. This could be helpful for contractures, but also people who've unfortunately had amputations and help make the hand a more functional appendage again. The next thing we'll talk about is acroosteolysis. This is not well understood. And again, this is another kind of unfortunate complication that can happen, that people will lose digits, but not because of Raynaud's, directly at least. It's not known why this happens. This happens in a couple other rheumatic diseases, but basically the bone itself is resorbed. So over time, so this is like left versus right of before and after basically the disease. But this person had basically, you can see at the tips, there should be bone there, and there isn't. So the bone's being resorbed over time, and then kind of over time, the digit is no longer functional. It's probably from, again, this low blood flow, which definitely happens in systemic sclerosis. But this is thankfully fairly rare. I've only seen it a handful of times in scleroderma. But unfortunately, we don't know how to best treat this. It would make sense that if we think this is from low blood flow, it would make sense that perhaps being as aggressive as possible with the Raynaud's management might help, but there's no evidence of that. And this is just an example of this person who's lost a lot of length of their digits. And again, there's no amputation here. Just the digits themselves are shrunk as the bone is no longer present. But this is fairly uncommon. And then inflammatory arthritis. So this is kind of this overarching theme of rheumatology. This is what we treat in a variety of diseases where you have autoimmune attack against the joints, causing pain, dysfunction, etc., swelling. But this definitely happens in systemic sclerosis. I think it's underrepresented and probably missed because so many other parts of the disease are much more visible and much more severe. But there's definitely patients that have this. And it's important because this often will influence what we use. For example, I'm sure a lot of people listening are on mycophenolate for one reason or another for scleroderma. But mycophenolate, for example, doesn't really treat most cases of inflammatory arthritis. So if this is present, it may influence your kind of treatment plan, which of course you would discuss with your rheumatologist. Now, this is a picture of someone with systemic sclerosis and inflammatory arthritis. If all you had as the top picture as a rheumatologist, this looks identical to RA, basically. You can kind of see the swelling in the knuckles, even to the eye without feeling them. And people get these deformities, and these are different than the deformities in systemic sclerosis. This is swan necking, where you have this kind of from tendon damage, but this looks identical to an RA patient, essentially. You can kind of see on the x-ray there's some damage to the joints themselves. This person also has some calcinosis, which you can see on the x-ray as well. But this is just an example. I don't have many patients with this like very, very stereotypical inflammatory arthritis presentation, but people can have, swelling in their wrists, swelling in their elbows. And so it's just something to be on the lookout for that, may influence kind of some of the treatment plan. And so, in conclusion, systemic sclerosis can affect hand function and structure in, really a multitude of ways. Each individual complication really is managed a little bit differently. There's not a one size fits all. Every scleroderma patient has different features, and even each feature is very different severity. So it's really individualized from person to person. And I think it's fair to say we need better options, and hopefully more options are to come, and hopefully in several other years, if we redid this talk, there'd be more things to talk about. Is my hope. And thanks everyone for your attention. I really appreciate it.
Thank you so much, Dr. Macklin, for that fantastic presentation. We had several questions come in, so I'll go ahead and kind of jump right in. The first question received is for Amy. Amy, we had a attendee ask about some of your experiences with oral medications for Raynaud's specifically.
Sure. So, yeah, Dr. Macklin talked a lot about vasodilators, so I've been on them probably since the beginning of my disease. So Lipitor, losartan, those have helped. I've been on Bosentan, which has helped my circulation as well, even though it's for pulmonary arterial hypertension. Um, yeah, those are my big ones that I've been on. I've also tried like Revatio, Cialis, um, those that has helped too along the way. So it's really important to kind of discuss with your doctor some of the options because there are some out there.
Thank you, Amy.
Mhm.
And Dr. Macklin, for individuals who are experiencing some separation of the nail from the nail beds, do you know what may be causing this or how to treat it?
Yeah, so that's kind of similar to like the reverse of being fused, and it may be that they're kind of in a containment of each other. It's probably from this damage to the underlying nail bed tissue from these low blood flow areas. As far as separation, I don't think there's great evidence on how to best intervene with that. My suspicion is a lot of people with separation probably have poorly controlled Raynaud's as well. So I think what would probably make the most sense is trying to address any sort of underlying Raynaud's activity in most people. But yeah, I've had that happen as well in patients. It's very difficult to address, unfortunately.
Does sound unfortunate. And one attendee says they're having contractures on their elbows and lower arms. Is it normal to have contractures outside of the hands?
Well, I mean, I wouldn't say it's not normal. Of course, it's still, obviously part of the disease. So there's kind of different subtypes of scleroderma. There's diffuse and limited. And basically the definition is limited, doesn't go past the elbows and knees, and doesn't go on the chest. While diffuse does. So that is that is part of what sounds like, probably diffuse disease. That is definitely, unfortunately, part of that kind of subtype. People tend to get contractures and thickening up further. And that would be a reason that's going on to discuss other treatment options with your rheumatologist.
And this question is for both of you. What do you feel the role of OT and PT specialists should be? Okay, or I guess how involved do you think that role should be?
Do you want to go first, Dr. Macklin, or would you want me to?
Um, sh Sure, yeah. I mean, I'm not I'm not an OT or a PT myself, so I don't prescribe the exercises. Um, but essentially, I refer the vast majority of my patients. If I have a handful of patients where it's really Raynaud's limited, so I don't necessarily refer just for that. But if someone has skin thickening and develop even mild contractures, they should see PTOT because it's a much easier. I think the exercises work better in earlier stage disease. If we're waiting, that's well, I unfortunately do meet people that were undiagnosed maybe for a decade plus. That kind of skin is tacked down. It's really hard to loosen that. The time to hopefully intervenes early. So I refer almost everyone that has any sort of skin involvement.
Yeah. Yeah, I agree. I still, a lot of, I'll be honest and say not everything that OT did kind of helped me. I still had some contractures and some skin thickening and tightening, but it gave me the tools to kind of know how to take care of my skin a little better, to do the stretching, to keep kind of my skin as with the elasticity as much as I could. And yeah, so I learned a lot. I would recommend going um earlier the better as well too, because your skin is better in the beginning than it would be, now, 20 years later.
Absolutely, that makes a lot of sense. And we have come up on the hour. If it's okay with our speakers, may I squeeze in about two more questions or so? Um,
Yeah,
Perfect.
that'd be fine. I have time.
Awesome. Thank you. So the next question is there a typical onset time frame for calcinosis?
So it's very variable. Um, Usually, and I've had many patients develop it very late in their disease. It's usually kind of upfront, like pretty soon outside of like the non-Raynaud's features representing. And like I alluded to, some of the antibody profiles are higher risk for calcinosis. But I would say typically anyways, it's not impossible for it to develop at any time, but it's typically in the first couple of years of disease.
Thank you. And does anything in the diet worsen Raynaud's, i.e. things like Coca-Cola, sugar, anything like that?
So there is a very not great quality, but they did do there's a paper that kind of was a questionnaire, and there was a trend towards improved Raynaud's with what's known as a Mediterranean diet. And I will say a Mediterranean diet is kind of what has the most, and I wouldn't say it's a lot of evidence, but it has the most clear, consistent evidence across a variety of different diseases. So what is that briefly? It's basically plant-focused, very like almost zero red meat, almost zero kind of tasty, sugary stuff. Really, the protein source is like legumes, beans, with a little bit of poultry and a little bit of fish. It's not, it's kind of the opposite of our typical Western diet in some ways. Um,
Nothing good, no.
yeah, but that seems to be what has the most evidence. I don't think it would treat Raynaud's, but maybe a supplement.
Thank you. And we also have, is it safe to take any form of collagen supplements if you have scleroderma and it's affecting the hands particularly?
So that's an interesting question. I can't say there's any sort of study or anything I can point to that. I mean, but systemic sclerosis in general is too much collagen. I don't. I would be surprised if it did anything good or bad. Like I don't think I would be surprised if it worsened scleroderma, but the actual like what you see in the skin, there's a overabundance of collagen. So I don't know what taking collagen would address. So I don't think I would recommend it, but I can't speak to the safety of it.
If you're trying to take it for wrinkles, we don't have a lot of them. So I don't think it would be productive if you're trying to make your face like plumper for in terms of like getting rid of wrinkles or anything. I think with scleroderma, our skin's pretty tight.
Fair point, Amy. Yeah. And then the final question before we wrap up, we can touch on it from 2 points of view here. So the attendee asks, what does it take to get an official diagnosis of systemic sclerosis? They're presenting with Raynaud's, um, finger ulcers, and the physician has looked at their fingers through a microscope and said that the capillaries do look kind of off. So from your perspective, what does it officially take to get a diagnosis, Dr. Macklin? And then after, Amy, if you could speak on maybe a little bit about that diagnosis process from your point of view.
Sure.
Yeah, so another interesting question. So rheumatology, and so this is the field in general, is an interesting field in that the gold standard is expert opinion. So really, a scleroderma expert saying you have scleroderma is kind of the gold standard, but there are criteria. The criteria are research based though. I will say if someone does not meet those research criteria, you really need a good reason why. Because there's definitely people that are missed by it, but the intent of them is for trials. So there's a ACR ULAR criteria. So it's a scoring system. It's a combination of nail fluid capillary changes, of where the skin thickening is, um, whether there's any sort of organ manifestation, so mainly like lung involvement, whether there's an antibody present, and it's a scoring system. Now, are there cases that fall out of that? Absolutely, but the vast majority should meet those.
I would say from like a patient's perspective, I know it can be super frustrating. My disease diagnosis process, um, fortunately was a little easier than I've seen other patients. I was diagnosed probably within 3 to 5 years. But I think you have to advocate for yourself. You have to push forward. If you feel like you're not being heard by a physician that you're seeing or consulting with, then I feel like it's necessary and okay to get a second opinion. Not everyone in the world is correct about everything, even doctors. So I think if you're feeling a type of way and you're not getting the answers that you're seeking, find a scleroderma specialty center, make an appointment, get checked out by those people that see it every single day, um, and fight for your, the right to know what you have.
Yeah. Thank you both so much. I think you're absolutely right. And for those of you who are in search of a scleroderma research treatment center, you can check our website, scleroderma.org. We have a list there. Dr. Michael Macklin is actually part of one of the scleroderma research treatment centers. So you'll see a familiar face. But thank you so much to all of our attendees for joining us today. I want to give a huge thank you to our two speakers, Dr. Michael Macklin and Amy Gietzen, for joining us today. Do you have any parting comments for the audience?
Just say thanks a lot. I appreciate always the audience, and I hope we were helpful. If you guys have any other questions, you can always hit me up. I'm always willing to help. So, Dr. Macklin?
Yeah, I mean, very similar. I mean, again, I really appreciate having the opportunity to talk to everyone, and hopefully I'll see, maybe I'll meet some people, and I think it's in August in St. Louis. But yeah, I mean, we're most rheumatologists are pretty friendly. I mean, if you ever need help or you have like a more community rheumatologist and wants to reach out, and most of us, I can speak for myself, but most of us are happy to try to help, and we're really excited to hopefully make more strides with treating this disease, and I'm hoping we have lots more to talk about and say in the near future.
Thank you. And just to mention, there are tons of comments coming in through the chat, just thanking you both for the fantastic session. For everyone in attendance, this webinar has been recorded and will be posted to our YouTube. That's Scleroderma US is the name of the YouTube channel. It'll be on YouTube this Friday. Thank you again, everyone, for joining us, and have a wonderful evening. Bye.
Everyone.